Good morning, everyone. So today we will start with immunochemistry. So first, I want to know about how far or whatever you know about immunity or immunology, acquired and innate. Do you know the meaning of acquired and innate? What is the difference? So after birth, we acquire some immunity, that is acquired. And yes, even before birth, we have some protection against virus, bacteria. So that is innate. Okay. Anything else? Anyone want to tell about immunity or immunology? Anything, whatever comes in your mind. Okay, when immunity resists against the diseases, yes. Other than the definition, in immunology or immunity, any other word you know about this? Antigen. Then antigenicity, okay. Anything else? So he told me that it is the resistance power of our body against infections. So how this resistance, like what are the components, like how we offer this resistance to the foreign infective particle, virus or bacteria. There must be something in our body which helps us to fight against this bacteria or virus or parasite. So what are those things? Immunoglobulins and lymphocytes. So in our blood, there are mainly three kinds of cells: RBC, WBC, and platelets. So what's the main function of RBC? It transfers oxygen. WBC, what is the main function? WBC is the main defensive mechanism against virus or bacteria. And what is the function of platelets? It helps in hemostasis. Okay. So can anyone tell me from where these cells are coming or where they are being synthesized? These blood cells. Bone marrow. So they are synthesized within the bone marrow. So what is the most basic cells from which all these cells are produced? What? Hematopoietic stem cells. So they have two different forms. One is myeloid and another is lymphoid. So what are the cells that originate from myeloid? So if we just remember what are the cells coming from lymphoid, they are lymphocytes. So other than these lymphocytes, all the other cells, RBC, platelets, granulocytes, mast cells, monocytes, all are coming from myeloids. So these lymphocytes, so there are several types of lymphocytes. Can you name any one of them? B lymphocytes and T lymphocytes. And there are also some cells called natural killer cells, NK cells. So immunology, it is the branch of medicine that covers the study of immune system, the organs and the processes of the body that provides resistance to infections and toxins. So these organs, they are mainly thymus, bone marrow, and lymph nodes. Immunity is a complex biological system that can recognize and tolerate whatever belongs to self and recognize and reject whatever foreign. So immunity is the power of our body to resist against viruses or bacteria. So immunity can be hypo when it is not working properly, or when the immune cells of the immune system is hyperactive. So both are dangerous. If it is hypoactive, it is also bad for our health, and when it is hyperactive, it is also bad for our health. So there is a disease in which our immune system is suppressed, and everyone have heard and know something about this disease. So can anyone tell me the name of the disease? HIV. So what is the full form of HIV? Human immunodeficiency virus. And we also call it some other name. AIDS. What's the full form of AIDS? Acquired immunodeficiency syndrome. So it is itself saying that is we have acquired some immunity deficiency, and that's the syndrome. And what this HIV virus does, it affects the T cells. So our defensive power of the body gets reduced. That's a variant of T cells, that is CD4 cells. And there is when our immune system is hyperactive. I think all of us have suffered some point of time that, yes, that is allergy. So when our immune system is hyperactive, sometimes we get allergy. So here there are two things. One is self and non-self. So can anyone tell me what does this signify? One is self and another is non-self. So our body cells, self is the whatever protein our body has. Like all the WBCs, especially the T lymphocytes, B lymphocytes, they have to recognize our body itself. And then they can recognize whatever coming foreign from outside, inside our body, so that they can differentiate in what is our self protein and what are non-self protein. So this is immune system. So we can see it starts from the mucous membrane. Even our skin is also involved in defensive mechanism. Then tonsils, lymphatic vessels, lymph nodes, spleen, thymus, skin, bone marrow. All these are involved in the immune system. So now antigen. Antigen, any substance that is capable of stimulating an immune response. And what is this immune response? They are activating the lymphocytes. An antigen is any substance that causes your immune system to produce antibodies. So can anyone tell me from which cells produce antibodies? B cells. It is not exactly B cells, it is a modified form of B cells. So what is the name of that cell? Plasma cells. So this antigen can be proteins or complex polysaccharides. This can also be lipids and nucleic acid when they are complexed with proteins or polysaccharides. So antibody, also called immunoglobulin, is a protective protein produced by immune system in response to foreign substance or antigen. So suppose these are different forms of antigen. This can be a virus, this can be a bacteria, and we generally represent the antibodies with a Y shape. It has 4 polypeptide chains. And in this part, this Y, the upper part of the Y shape, here the antigen binds and then immune response is generated. So here we can see these are the hematopoietic stem cells. From here we have 2 different divisions. One is myeloid progenitor cells, another is lymphoid progenitor cells. From these lymphoid progenitor cells, we are getting all the lymphocytes, T lymphocytes, B lymphocytes, and natural killer cells. And all the other cells are generated from myeloid cells. So now we come to, there are three different variants of T cells. One is helper T cells, another is cytotoxic T cells, and another is regulatory T cells. So here the helper T cells, they are also called CD4 cells. The cytotoxic T cells, they are also called CD8. And regulatory T cells, they have different markers. So these CD, they are some protein on the surface of the cell by which we can recognize what kind of cell they are. They are like the name of a cell. So here we can see that these are the B cells. These are the two variants of T cells. And this is a variant of T cells which regulate all these cells. These are the regulatory T cells. So here we can see during the development of these T cells or B cells or lymphocytes, they get different markers on their surface. So first they are starting with the stem cells. And all the cells, they have this common CD45. And the full name of CD is cluster of differentiation. So during the developmental process, they acquire these extra proteins on their surface so that they can be distinguished. But we have to just remember the different variant of T cells. One is CD8, CD4, and regulatory T cells. Regulatory T cells, they have CD8, but when we just see CD8 cells, they generally mean cytotoxic T cells. Like here, all the cells have CD45, but we don't mention this CD45. So first, we have to know recognition of self. Then the immune reactions are highly specific, and there is memory response to immune system. So what are these? Have you ever heard of MHC molecules? Major histocompatibility complex. So these things are like what? They are proteins. They are present on the surface of the cells. This MHC class 1, they are present in all nucleated cells. So what they do? Graft. They have role in graft rejection. But what is their main function? Normally, we don't have grafts, right? So that's in a diseased condition. Yes, they just represent the antigen. So the self-antigen, whatever our body produces, they are represented by these MHC class 1 molecules. And whatever non-self, they are represented by these class 2 MHC molecules. So they are important for recognizing self and non-self. So among all the different variants of the WBCs, these three variants, one is dendritic cell, macrophage, and B cells. They have a special name. It is called antigen presenting cells. So what they do, they first engulf the virus or bacteria, and then they present a part of this virus or bacteria with the help of what kind of MHC? MHC1 or 2? MHC2, because MHC1 that presents self. So these are non-self. So this they will represent with the help of MHC2, and then they will activate other WBCs. So these three are called antigen presenting cells. So here we can see this is a normal cells. A virus attack this cell. Then the viral protein is synthesized within the cell. Then this protein is placed on the surface of the cell with the help of MHC class 1 molecule. So why this viral protein is presented with this MHC class 1 molecule? This is non-self, right? Yes. So what virus is doing, it is synthesizing its protein with the help of our protein synthesizing mechanism of our own body. So that's why they are represented with the help of MHC1. Even when it is representing the protein, it has to be killed. So there are specific type of cells, cytotoxic T cells. What they do, they can specifically recognize, they are trained to recognize the self and non-self. So during their development, they know that even if some protein which are non-self, if they are represented with the help of MHC1, they will kill the cell. So this is a specific function of cytotoxic T cells. These are cytotoxic T cells, not helper cells. CD8 T cells. So here, this is macrophage and this is B cell. So both of them are antigen presenting cells. So see, this macrophage has engulfed some pathogen. And then this macrophage will process this pathogen and represent it with the help of MHC class 2. Then this MHC class 2 along with this processed antigen or the foreign antigen, they will interact with the T helper cells. So now when this macrophage is interacting with the helper T cells, these helper T cells release certain kinds of chemicals. They are called interleukins, IL. There are many kinds of interleukins. So once they are interacting, these helper cells gets activated. And then they can form two variants. One is effector T cells and memory T cells. So when the memory is formed, it stays in our body. And when there will be a second infection, these memory cells will proliferate and help in our defensive mechanism. So here also, as it is also a antigen presenting cells, it will also process the antigen, foreign antigen, and present it with the help of MHC class 2. And it is also similarly activating T helper cells. So now this is the same. This is the macrophages antigen presenting cell. This interacting with the helper T cells. Now the helper T cells are getting activated. Now these helper T cells can also combine with another B cell. Then it will secrete, the helper T cells will secrete the interleukins. Then this B cell will get modified into either plasma cells or it can get modified into memory B cells. So this memory B cell will be stored in our body and these plasma cells will go on producing immunoglobulins. So can anyone tell me what is this process? Probably you have already read in physiology. Phagocytosis, yes. So what is the first step? So there are some proteins, opsonization. So what is happening? These bacteria, they are getting covered with immunoglobulins. Now the immunoglobulin covered bacteria, they are attaching with the macrophage. The macrophages have these yellow vesicles containing lysozymes. So after this phagocytosis, with the opsonized bacteria, this phagosome will combine with lysosome. So what is the combination called? Phagolysosome. So now here the bacteria will be digested and then MHC MHC2 molecules. So this is the opsonization and phagocytosis. This requires the help of immunoglobulins. And what is this C3b? Yes, but from where? What is the main system from which this C3 molecule is coming? So here also the same picture, the macrophage, it is engulfing the infected cell. Then this macrophage is interacting with helper T cells or memory T cells. So these are cytokines. Cytokines are also a form of interleukins. So then they are dividing these T cells. These T cells, similarly as B cells, also form effector cells and memory cells. And then these cytotoxic T cells interacting with the infected cells and killing this cell. So this is the B cell, this is T helper cells, interleukins or cytokines are released, plasma cells or the effector cells are produced, and some are B memory cells. These are stored in our body. So now this is CD4 cells. So CD4 cells can be of various types. One is T helper cell 1, T helper cell 2, T helper cell 17. You don't have to remember everything, just remember the names. So there are 3 kinds of helper cells that are important in our body. So now these are the natural killer cells. So you just take a look at this picture, and can anyone tell me what this picture is signifying? What is the significance? So here we have class 1 MHC. So we know the function of class 1 MHC. It presents the self-antigen. And it is a tumor cell. So what is the difference between this healthy cell and the tumor cell? Because the healthy cell is also interacting with the NK cells, and the tumor cell, it is also interacting with the NK cells. But the NK cell will kill this tumor cell, but will not kill this healthy cell. Inhibition is less. So these are the molecules, MHC class 1. So they are much more numbered on the healthy cells. And when a cell is abnormal, then the number of MHC1 class proteins on the surface, they are reduced. So the NK cells will kill these tumor cells, but due to the huge number of inhibition from these MHC class 1 molecules, this normal cell will not be killed. So now we have this MHC class 1 molecules in infected cell. They are producing some kind of protein. So MHC class 1, what kind of protein will be here? Self or non-self? Self. And what is these cells? Cytotoxic T cells. So it is presenting self protein, but why it is getting killed? Exactly. It is similar to the previous picture what we have seen. So here some virus has infected these cells, and the virus has hijacked our own protein synthesizing machinery. So what is this machinery? Can anyone tell me any name? How is protein synthesized in our body? In translation, what is the structure? Ribosome. So ribosome helps in the synthesis of protein. So here viral protein is represented. That's why once the CD8 cells interact with the MHC class 1 molecules representing the viral protein, it will recognize it and then it will release some chemicals. They are generally called perforins that produce a hole on the infected cell, and the granzymes. These are enzymes that digest the cell. So once this interaction is done, the infected cells dies. So here we are seeing some allergens. Can anyone tell me the name of any allergen? Pollen. Then dust. Dust can contain many kinds of things. Then drugs. তোমাদের কারোর কোনো অ্যালার্জি নেই? হ্যাঁ, কি? চিংড়ি, prawn, brinjal. So depending on the person, any protein. Have you heard of people having they are allergic to tomato? So anything can be allergic, depends on the person. So here, what is this DC? Dendritic cells. So this is also antigen presenting cells. So it will first engulf this foreign allergens. Then it will interact with the T cells or a variant of T helper cells. So there will be release of interleukins. With the presence of this interleukin, they will influence the B cells. The B cells will produce immunoglobulins. And these immunoglobulins, with the help of these cells, these are involved in allergy. So what are these three cells? The most important is mast cell, then eosinophil, and then basophil. So can anyone tell me what are the different kinds of immunoglobulin in our body? G, A, M, D, and E. So allergy, this is specific to this IgE. So here also we can see that these immunoglobulins, they are initiating complement system. And this complement system is producing a hole on the surface of bacteria. And in the process, killing the bacteria. So here we can see this is the complement pathway or the complement cascade. So the net effect is producing a hole on the bacteria. And here we can see these immunoglobulins. They are initiating this complement cascade. Okay, now we can see that these are the two main types of immunity. One is innate and one is adaptive. So both the types of immunity interact with each other. They cannot work totally separately. So they have to interact with each other to protect our body. But for our convenience, for our learning, we make this division. So in adaptive immunity, what are the two main kinds of cells? They are the T cells and B cells. And most other cells are involved in innate immunity. So what is the first defense in our body? They are the skin, mucous membrane, cilia, body temperature, and pH. So in the mucous membrane, suppose, so where is this mucous membrane present? Respiratory tract, GI tract, and can you tell me any enzyme that is present in our saliva or tears? Lysozymes. So they are all the first defense in our body. They are the physiological or physical barriers. Then comes the cells, neutrophils, basophils, eosinophils, macrophages, mast cells, dendritic cells, and natural killer cells. So, innate immunity is something that is already present in our body from birth. It is non-specific. It is rapid in response. It has lower potency and have no memory. Adaptive immunity. This is created in response to exposure to foreign particles. These are specific. These are slow, high potency, and have memory. So this is the classification. So innate and acquired. So acquired can be active and passive. So can anyone tell me the name, not the name, what is the meaning of this active immunity? This is, so active means our body is working, our body cells are working. Passive, from outside, these cells or immunoglobulins are inserted in our body. So can you tell me any example? Colostrum. Okay, then when the fetus is synthesized in the mother's womb or the uterus. What? IgA or IgG or IG? IgG. So IgG can cross the placental barrier. But why not the other IGs? So the main defense comes with the IgM and the IgG. IgM is much bigger in size. Afterwards. But main thing, IgM is big, IgG is small. That's why it can cross. But IgA, that is also coming in the baby's body. From where? Colostrum or the milk. Okay. Any okay, from the next class we will continue after this.
2 days of inspection is going on, the second day, and we hope and pray also the inspection goes up well. It's going on well. You need not worry from your side. And with today's lecture, the scalp. Now, scalp, I just introduced you just the parietal bone. Today we will go, it's a small lecture, but it's a vital lecture also. And the clinical importance is tremendous because road traffic accidents and are on the rise. So every, like in Indian cities, Delhi is having the maximum number of RTA, road traffic accidents. Calcutta, with Safe Drive and Safe Life slogan, to some extent it is in the bottom line. Now, there is a thing is that anyone who becomes stubborn or something like that, and there is a saying, a hard nut to crack. Yes, it's truly the skull and the scalp. It is hard nut to crack, but the anatomical disposition of the scalp is such that it's minor cut injury or blood trauma, especially cut injury, small injury, cut through the scalp, there's profuse bleeding, and now these are the layers of the scalp. This is the skin, this is connective tissue, aponeurosis, loose areolar tissue, periosteum, bone. This is the cerebral cortex. These are the venous sinuses. Now, soft tissue covering the claviria of the skull extends up to the supraorbital margin in front, external occipital protuberance and superior nuchal lies behind. Now, the eyebrows here in the frontal bone, it is up to the occipital protuberance and the superior nuchal line. Yesterday I told you a story about Professor Jackson, that you can, when I happened to see a workshop in Amri, Kolkata. After seeing that workshop, I have no fear of any type of injury in the scalp. He made an incision and it has a zygomatic bone trauma, facial distortion. He had the operation doing on a patient. What he did is in the external occipital protuberance and superior nuchal lie behind, he just made an incision and brought the skull down like you open your gloves, degloving. Like that, the scalp can be brought up to this level and down more. Now, and the zygomatic arch on each side. This is the boundary. Now, again, it's a repetition. The layers of the scalp, skin, subcutaneous tissue, aponeurosis, gallia, aponeurotheca, loose subaponeurotic tissue, and pericranium, the periosteum. Skin, connective tissue, aponeurosis, loose areolar tissue, periosteum, and the bone. Now, the subcutaneous tissue, the closed network of fibrofatty tissue, contains blood vessels and nerves of the scalp. The walls of the vessels are firmly adherent to the fibrous tissue. Minor scalp injuries result in profuse bleeding. Now, the basic anatomy is that's why if there is an injury, you just your dupatta, you tie, or gamcha, whatever you get in hand, you just tie tight, the bleeding will stop. Now, the gallia aponeurotica, situated between the occipital bellies and frontal bellies of the occipitofrontalis muscle. Now, occipitofrontalis, the frontal bone and the occipital bone behind. It is extending from this. Now, the muscles, the occipital bellies and frontal bellies of occipitofrontalis muscle. Here, the occipitofrontalis and posteriorly the occipital bellies attached behind to the external occipital protuberance and highest nuchal line. When you see the occipital bone, then you will see there is the superior nuchal line and it is attached there. And in front it blends with the tissue of the nose, and on each side you just see your zygomatic bone here. You can see it gets attached there. Now loose subaponeurotic tissue. Now loose subaponeurotic tissue consists of loose areolar tissue, contains emissary veins devoid of valves, dangerous area of the scalp, collection of blood in space produce generalized swelling, black eye, head injury with pericranial tear, safety valve hematoma, traumatic vault fracture with meningeal tear, capellohydrosis. Now, you see a patient comes a second day to your outdoor with swollen head, swollen this thing and a black eye. That signifies there's a scalp injury there. And what are the things immediately you have to do? He got a first aid, or he says, he just tied some, told you, dupatta or gamcha, anything comes to you. Naturally, you just take your assistant, help, tell him or her to press the area where it is injured. It might be a cut injury. So, you can see as you open, just press and release, and you see if there is bleeding. Then you have hemostatic forceps. Prior to that, you just inject xylocaine 2%, and that gives local anesthesia. Naturally, if you tie, then you press, then there is the clean, debribe the wound, clean the wound, and see for any, locate the blood vessels, and then you tie it, clean, debribe the wound. You might be, that might be some dust, even some small sand particles in this. You just clean, and don't hesitate. You can take a shampoo pouch after you give quick your sutures. You oppose the skin, and then you just put your, like in the salon, you go to shampoo and clean, and then you put a antiseptic dressing and you manage the bleeding scalp. And the basic anatomy is such that is the reason it bleeds much. It might be a small cut here, but if you cut, you make an incision, there is less bleeding in the abdomen, leg, anywhere, any other parts, but scalp bleeds profusely. Now, the pericranium, the outer periosteum of the skull, at this suture line continues with the endocranium. Collection of fluid produced localized swelling assume the shapes of related bones. Now, as I told you, the attachments of the skull. Now, if there is hematoma, the temporal region is limited to the zygomatic arch. It doesn't go down. It is there. It is like this. Actually, if there is a trauma, there's collection in the hematoma, then it is getting the collection. The collection of fluid produces localized swelling, as in the shape of the related bone. If it is in the front occipital bone, it will be roundish, taking the shape of the now if there is a collection, there is hematoma like this. It will take a swelling over here, bulge. Now, if it is a blunt trauma and after radiological investigation, the basic X-ray or radiograph of the skull, AP lateral view, you take and see a soft tissue shadow of due to the digitalized X-rays, you can see the soft tissue shadow. Now, if it is in the emergency, immediately you don't try to drain or clean that part unless you have a very good setup. And now, yesterday I showed you the two parietal bones sutured. Now, go to the endocranium, the collection percolates. The nerves and arteries of the scalp. Now, why it is important to know that the small sebaceous cyst, small dermoid, you don't need general anesthesia. You just block along the, if you know the anatomy, you just block along the nerve supply with xylocaine. And then you operate. Of course, before that, you trim, shave. If there is a small 2 centimeters by 2 centimeters sebaceous cyst, which is very common in the scalp, or the dermoid cyst. And if you have any like vascular, like hemangioma or something like that, you just put your finger pulp on the swelling and see if there is any pulsation and if it is compressible or not. So that you need a bit better setup. And that hemangioma, you want to more be sure of your diagnosis, then you take a 5 ml syringe and you just puncture and see if too much of blood is coming. If any swelling in the neck or anywhere, with a pulsating swelling.
জেনারেল শোনাই যাচ্ছে না।
If it is a pulsating swelling, then you see the nerve supply in the supraorbital nerve. Now this is the orbit when you read the frontal bone, you will see it is in this slide. So, according to the bony relation of the specific nerve, it is named. Now, front of the auricle and behind the auricle. The nerve supplying in front of the auricle and the nerve supply behind the auricle. Now, front of the auricle is supratrochlear, supraorbital, zygomatic-temporal nerve, temporal branch of facial nerve, and auriculotemporal nerve. Auriculotemporal, temporal bone, related to the temporal bone. So, the nerves, if you relate with the bone, then you can remember easily. Similarly, behind the auricle, posterior branch of great auricular nerve, posterior auricular branch of facial nerve, lesser occipital nerve, greater occipital nerve, C2, and third occipital nerve. Now, similarly, the arterial supply of the scalp, front of the auricle and behind the auricle. Now, supratrochlear artery, supraorbital artery, superficial temporal artery. Now, the total blood supply, ma'am, I think the
Hello.
screen is here. It's up to you to see or not. But you have no right to disturb anyone. Now, behind the auricle, the posterior auricular artery and occipital artery. Now, the venous drainage of the scalp. You can see the blue tributaries and branches of the venous system and the periostal superficial temporal vein, the frontal, the parietal tributary of the superficial temporal vein, the frontal tributary of the superficial temporal vein, the temporal the muscles and the temporal muscles, and here this is the supratrochlear vein, supraorbital vein, deep temporal vein, emissary vein of the cavernous sinus, angular vein, external nasal, intracranial, infraorbital vein, palatine. These vessels are going deep when you, and then they drain the external jugular vein, internal jugular vein. And this is the facial vein, this is the superior buccal, inferior buccal or labial. Similarly, posterior auricular vein, maxillary vein, occipital vein. This is the superior auricular. The maxillary vein here, occipital vein here, pterygoid venous plexus, inferior alveolar vein, posterior branch, retromandibular vein. Now, when you see the mandible, the retromandibular, behind the mandible is the retromandibular vein, the posterior branch and the anterior branch, and external jugular vein and internal jugular vein. Now, venous drainage. Now, supratrochlear and supraorbital draining into angular vein. Angular vein continues as facial vein. Superficial temporal plus maxillary goes to the retromandibular vein. Anterior division of retromandibular vein and facial vein goes to the common facial vein. Common facial vein drains into the internal jugular vein. The posterior auricular vein plus the posterior division of retromandibular vein goes to the external jugular vein. The occipital vein terminates in suboccipital venous plexus. Now, this is important because children, their mother comes with a complaint that, Dr. Babu, there is some swelling in the neck. Your first question will be, did he have any impetigo or abscess in the scalp? Don't think that, of course you have to bring it into your thought that neck gland swelling in a child or in an adult, it has different significances. But most common in our country is any boys or children having the neck swelling, neck gland swelling is due to the infection and it is draining into the lymph nodes, the policeman of the human body, lymph nodes. Now, over there, the lymph nodes try to resist and then naturally there is the inflammatory reaction, inflammatory changes and that swells up. Now, you just take the history, clinical history. Now, if she says, the mother says, there is no such episode or any of this abscess or impetigo or minor injuries, then think of, most commonly, think of our tuberculosis. Now you have to do some investigation and you ask her if the child was given a vaccine in the when he was born. Now with this, now in the adult, any neck swelling, you think of tuberculosis, you can think of Hodgkin or some lymphoma that is due to the malignancy, or a parotid swelling with a similar neck swelling that might be a carcinoma of the parotid leading to the, now it's draining naturally, now lymph vessels in the anterior part of the scalp and forehead drain into the submandibular lymph nodes. The total, if you clinically, if you see it over here, there is swelling there. Now, submandibular lymph nodes, or it is the submandibular gland swelling. Now, you do an FNAC, fine needle aspiration cytology, and see the difference. Then you do a complete hemogram to see any changes in the blood picture, any blast cells are there or not. These are the basic, you don't go for a CT or MRI of the scalp, brain and all this. You just see it clinically and now see the lymph nodes here, this part. The anterior part of the scalp, submandibular nodes, deep cervical nodes, superficial cervical nodes. Now, we are relating to the occipital node. We are relating our talk on the scalp. But neck swelling, even the on the just say over here, over there supra superficial cervical nodes. Now, just above the clavicle you have read, if in the left side there is a big swelling, that is known as Virchow's gland. That is any gastric carcinoma that drains up there, and that might be a picture presenting with other symptoms and signs. But as you are going to study your head and neck, naturally, just I am giving a reference. Now, you can see this is the parotid gland. Now, the parotid drainage for the lateral part of the scalp and the ear is into the superficial parotid preauricular nodes. Lateral part and scalp above the ear. Now, retroauricular, behind the ear, mastoid group. Now, the lymph vessels in the part of the scalp above and behind the ear drain into the mastoid node, this portion. So, every region is having the lymph nodes or the lymphatics. That portion or that region of the specific area of the scalp can be related, you can relate it anatomically, and the portion that is being drained goes and drains into the lymph node of the respective area. Now, vessels in the back of the scalp drain into the occipital. This. You just know what I am telling you, the fundamental. The head and neck, don't be shocked or don't be, क्या बोलते हैं? Simon, what do you say, right? Syncopal attack. It is not that. It is the bone, the ears, you divide it into two areas, posterior to the ear, anterior to the ear, and the respective lymph nodes in the area occipital, retromandibular, behind the mandible. Like this, you retain in when you are studying. Now, the deep cervical nodes, the vessels in the back of the scalp drain into the occipital nodes. All these groups of lymph nodes are drained into the deep cervical group of lymph nodes. All this drain ultimately, all the roads lead to Rome. All roads lead to Splanid, Dharamtala. All roads lead to Mal, Darjeeling. Now, the surgical plane, loose connective tissue. Tissue expanders are inserted here. Loose connective tissue is also the dangerous area of the scalp. Reason, blood and pus due to injury are accumulated here, can spread to dural venous sinuses and meningitis, and then may lead to thrombosis. The black eye and cephalohematoma are also related to scalp. Now, any surgical intervention, any injury of the scalp or related to the head, you please give a shot of antibiotic before doing anything, because of this reason. Say you forgot in a hurry to give an antibiotic, but you have written a prescription, that is the victim is, the injection was given after 6 hours or 12 hours, or you have to be not all this type of traumas. You don't go for low dose, low power, not wide spectrum antibiotics. You give a broad spectrum antibiotic, and because to give an antibiotic coverage to be in the same time. If say he's not given an antibiotic, he reports to you after 12 hours with stiff neck and also spasms. So you make him lie on the table and see if you can extend or flex the neck, or you just flex your at the hip joint and pull, then there might be signs of meningitis. But nowadays, before you give a shot, some assistant to the physician, or popularly we call them quacks, because in remote areas you don't find doctors, but this, I'm saying assistant to the physician, say a boy who was working with me for a couple of years, 5 years, he goes back to his place and he practices. Okay, now he all practices means he's following your path, your prescription, your ways, and he prescribes it. Naturally, there's a coverage already. Previously, only penicillin, then tetracycline, these were the drugs. But third generation, fourth generation cephalosporins and other antibiotics. Plus, one thing I tell you, any trauma you handle, you nourish. खून का बदला खून, पानी का बदला पानी. If you have diarrhea, dysentery, anything, you replace with not only ORS. If you see the previous part, you replace with IV infusion of different electrolytes. And in that similar way, you just have a quick access to the hemoglobin percentage, or clinically you see he lost too much of blood by the head injury. Then you can see if you then you give it, if you are in a hospital, I'm saying, then you give a order for an hemoglobin, and if you see if it is below 9 or 8, then you go for a blood transfusion. Because it will depend on what type of trauma it is. So, and this can spread to dural venous sinuses, meningitis, and that may lead to thrombosis, black eye, and cephalohematoma also related to the scalp. I told you in the beginning that if you give a blood trauma, some man comes with a black eye or a red eye, then you think that he has some trauma, he will give you a history. But you don't have to go in an aggressive, like draining and this thing, that will resolve after giving some modern drugs are there, chymotrypsin, trypsin, all these drugs are there, anti-inflammatory, that's analgesics, and also antibiotics. Now, you'll be think your bones will be taut. Please, it is very, I have told Suresh, you take out the 2 or 3 skulls are there. You take whenever your teacher is demonstrating. So, iron or some person with the child will take the responsibility, and then you, like yesterday, 5 parietal bones, I gave it to the students, to your friends, whoever it is. So you just correlate, and you see the whole skull, and see it is don't like head and neck, probably brain. Don't. It will be done. You're in the last lap you are now of the marathon. So Please again I'm telling you, repeating, in the dissection hall and the lab, please spend at least 2 hours or 2.5 hours taking out bones or this thing which is being taught to you. And those who have missed, please take out for half an hour every week or 1 hour time to revise and to learn from your colleagues or your friends. You have beautiful books with beautiful atlases and the teacher is there. With this, I wish you all the best. Thank you.
Okay, and how many students had attended the class of nuclear copy? Raise your hand. Here is the others. That is the problem here. Understand? That is the main problem. Here we complete the practical of demonstration of quantitative estimation by GOD method, quantitative estimation of blood glucose by autotherapy method. But most of all of you are upside. Only one. The theory practical Here, no. April. What I say, yes, simply. Here, you know the quantitative estimate procedure of two methods. The first one is enzymatic method, that is UD-PUD method and exokinase method. And the second one is non-enzymatic method, that is orthotolerant method, King and Astute method, Nelson Samoa method, foreign Gu methods. So all these are the different methods for quantitative estimation of blood glucose. Okay, and here we perform the test mostly by GOD-POD method. Okay, so why I am telling to all of you, because after 15 minutes all of you perform this practical. Understand? So at least you know the principle of this test and the procedure of this test. GOD-POD, glucose oxidase peroxidase method of quantitative estimation. Okay, the principle is very simple. Okay, the principle is very simple of GOD-POD. What is GOD-POD? Glucose oxidase peroxidase method. That is the enzyme which is act on the glucose to make gluconic acid and hydrogen peroxide. When this hydrogen peroxide reacts with phenol and 4-amino antivirin, it is changed into phenol-amine complex, which is red color complex, and we measure the intensity of this color at 530 nanometer for to know the concentration of the glucose. Okay, so the principle and procedure is what? Take 20 microliter of test, distill water in the standard solution in each of the test tube, and after that we add 2 ml of GOD-POD reagent in the each test tube. The final volume is 2.20 microliter, 2.2 ml. Understand? So the procedure is very simple. All of you know that first of all, today we perform the quantitative estimation of blood glucose by GOD-POD method. Okay? So I think most of the students are absent. So at least you will write the principle and the procedure of the test. Okay? In your copy. And after reading this procedure, you will perform this practical. And those students who will complete this practical in a manual can spread and send to all the students. Through this, you can write in your copy in the manual. Okay? So today we perform quantitative estimation of blood glucose by GOD-POD method. Okay, the principle is, what the principle of this test? When glucooxidase and peroxidase, when glucooxidase and peroxidase act on glucose, act on glucose, act on glucose, it's make gluconic acid, it's convert glucose, I repeat, it's convert glucose into gluconic acid and hydrogen peroxide, and hydrogen peroxide. Full stop. When this hydrogen peroxide, when this hydrogen peroxide react with phenol, react with phenol, okay, and 4-amino antipyrine, and 4-amino antipyrine, it's form quinoamine complex, quinoamine complex, quinone, Q-U-E-N-O-N-E, quinoamine complex, ब्रैकेट में लिखिए रेड कलर, quinoamine complex, red in color, and we can estimate the concentration of glucose. We can estimate the concentration of glucose at 530 nanometer. We can estimate the concentration of glucose at 530 nanometer. Okay. Now write the procedure. Procedure is simple. You write it. Take 3 test tubes and mark them as a test, blank and standard. Take 3 test tubes and mark them as a test, blank and standard. And make a table. Make a table in which first column is reagent and rest 3 are test, blank and standard. As per the criteria you will make the table. All of you make the table. Which heading you make? The first one is reagent. Second one is test. Blank. Standard. Okay. Now first we take our distilled water. Distilled water. We add 20 microliter in black test tube. How will you add 20 microliter? हाँ? ये क्या होता है? Yes, it is U like structure. You microliter, 20 microliter in test and black the rest of it. After that, write its sample 20 microliter in T test tube. T test tube 20 microliter राइट लिखना उसमें, बाकी में टेस्ट कर देना. And write standard solution 20 microliter S test tube. 20 microliter S test tube and GOD POD reagent that is 2 ml in each test tube. 2 ml in each test tube. 2 ml in each test tube. Okay. Leave for 10 minutes. Leave for 10 minutes at room temperature. Hey, Suri Saka. Why are you sleeping here? What are you doing? So do you? Heat the test tube for 10 minutes at room temperature and take OD at 530 nanometer. And take OD at 530 nanometer. Now, what is the calculated formula? क्या बोला? क्या है ना सब लोग बोलते हो गया हाँ भाई क्या बोला बता into 2 good very good the concentration of the standard is different in the creatinine the concentration of standard is 2 mg per dl okay last lecture listen carefully the concentration of the creatinine test is different that is 2 mg per dl but the concentration of standard in the blood glucose is 100 mg per dl so the formula is what OD of test minus OD of blank upon OD of standard minus OD of blank multiplied by concentration of standard upon volume of sample multiplied by 100. So the calculated formula because we here perform this test on PFF protein free filtrate. When I will teach you the auto-tolerating test, I will show you how the concentration is comes here 100 mg per dl because there is C upon B into 100. Concentration of standard is what we take. There is overall the calculating method is overall the value is giving here OD of test minus OD of blank upon OD of standard minus OD of blank multiplied by 100. Understand? We perform this test on PFF protein free filtrate. I will tell you in the previous class how this protein free filtrates are comes out. It is comes out by the use of TCA tricarboxylic acid. Okay? So the calculated formula is OD of test upon OD of blank, OD of standard minus OD of blank in each denominator and numerator and finally multiply by 100. That is the calculated formula. Okay? What is the normal blood glucose level? Fasting blood glucose normal? How much is it? 70 to 100 mg per dl. Postprandial? 100 to 140 mg per dl. Random blood sugar? Up to 140 mg per dl. Okay, these all are the values, normal values of blood sugar. How can you say a person having hyperglycemia? The value is becomes over from 160 180 mg per dl. And 160 to 180 and more than 180 mg per dl, you can say that the person having hyperglycemia. Understand? Hyperglycemia. And how the person become hypoglycemia? If the value comes nearby 70 mg per dl. Okay?
अच्छा हमारे नाम को मंच को भी बोला तो don't know now for this topic diabetic mellitus what is the definition diabetes is metabolic syndrome metabolic disorder or syndrome characterized by how many types of diabetes? Type 1 diabetes, diabetes mellitus is two types. Type 1 and type 2. There is another diabetes. Why this type of diabetes suffered? What is the function of diabetes? Reabsorption of water from collecting tap. Very good. Type 1 and type 2. Now, focus is on the type diabetes mellitus. This is two types of diabetes mellitus. One type 1 and type 2. What is the cause of type 2? Do you know? Receptor problem. Autoimmune disease. Age group is side age group near about below 50 as per your books. This is within 15 years of age. And another two is another type of diabetes type 2, which occurs mainly in case of young adult age group. As per your book, is more than 15. So, what is the cause of type 1 diabetes and type 2 diabetes? Type 1 diabetes is mainly due to autoimmune disease. Okay. In case of type 1 diabetes, there is no secretion of insulin or there is total absolutely deficiency of insulin. That's why glucose cannot be utilized. Okay. Clear number. Yes. You have the number. What is the cause of type 1 diabetes? Next, I am coming for type 2 diabetes. Type 2 diabetes is due to insulin resistance. Okay. There are many causes of insulin resistance. One of the causes of obesity. Insulin resistance. What is the meaning of insulin resistance? Do you know? Hello? What is the meaning of insulin resistance? It is where the insulin is not deficient. Right? You can say there is normal insulin or hyperinsulin. It is due to receptor level problem. Insulin cannot be act on the glucose. That's why body cannot utilize glucose. Okay, peripheral tissue cannot utilize the glucose. That's why the hyperglycemia occurs. Okay. Sure. Clear? No. This one. Type 2. Type 2 power. Type 2 actually determines the insulin. Type 1 is the insulin secretion high. Beta cells when S is destroyed due to autoimmune disorder or autoimmune. Autoimmune disorder is same reaction happen. Again. শুনতে পাচ্ছিস? autoimmune disease তো হয় সেম ডিস্ট্রাকশন happen. মানে টাইপ 1 এর ক্ষেত্রে autoimmune disease হওয়ার জন্য প্যানক্রিয়াস বিটা সেল থেকে ইনসুলিন সিক্রেশন হয়। ঠিক তো? নাকি না বা? আচ্ছা মানে আমি ঠিক আছে বিটা সেল থেকে ইনসুলিন সিক্রেশন হয় তাহলে বিটা সেলগুলো ডিস্ট্রাক্টেড হয় তাহলে ইনসুলিন সিক্রেশন হচ্ছে না মানে ডেফিসিয়েন্সি অফ অর টোটাল অ্যাবসেন্স অফ ইনসুলিন হয় আর টাইপ 2 এর ক্ষেত্রে যেটা হয় পেরিফেরাল টিস্যু লেভেলের প্রবলেম হয় রিসেপ্টর লেভেলের প্রবলেম দ্যাট body cannot utilize the glucose that's why hyperglycemia occurs okay next how to diagnose the what is the criteria of diagnosis of diabetes mellitus anyone from who criteria neutrophil criteria as per whom as per meta-guideline American Diabetic Association guideline who guideline there was probably a question at your exam yes or no
HbA1c is the best issue.
HbA1c total level এ একটা ইয়ে নয় মানে এখন আমি প্র্যাকটিস করি আমার লেভেলে HbA1c খুব ইম্পর্টেন্ট মানে বেস্ট ইম্পর্টেন্ট বাট তার আরো কিছু আছে সেই ক্রাইটেরিয়াগুলো বলা হয় Another,
Sir, fasting.
Fasting.
126 mgdl history. OGD.
fasting, GTT কোশ্চেনটা ঠিক ছিল না। GTT only used for GT মানে gestational diabetes mellitus diabetes, not for fasting. Fasting what? Actually, what you have read in your book, it is completely incorrect. As per correct header guideline, it is 100. Less than 100 is diabetes normal. More than 100, it is pre-diabetic. Do you know what is the pre-diabetic condition? মোটা মানে আমরা বলি না যে একটা লোক মোটা হয়ে যাচ্ছে, একটু মোটা হয়ে গেলে তো ওবেসিটি ডেভেলপ করছে, আর একটা লোক 1 কুইন্টাল ওজন ও মোটা হয়ে গেছে। এই ব্যাপারটা এরকম। ডায়াবেটিস হলো আগের স্টেজটাকে আমরা বলি প্রি-ডায়াবেটিক কন্ডিশন, ঠিক আছে? ইট ইজ 100, more than 100, less than 126. Okay, pre-diabetic condition. Diabetes more than equal to 126. First criteria of defined type 2 diabetes is more than fasting blood sugar more than equal to 126 milligram per day. Okay, বুঝলি? এটা কিন্তু তোদের বইয়ে ভুল লেখা আছে। কারণ আমি যে বইটা পড়ছিলাম দেখলাম 110 টাকা আছে ফাস্টিং, এখন 110 কোথাও নেই। As per guideline is 100 fasting. Next হচ্ছে random blood sugar more than 200 milligram per day with symptoms of hyperglycemia. Key symptoms: polyuria, why polyphagia or polyphagia or polyuria?
The cell is not taking enough glucose.
Next, এটা জানো যে কোনটা?
Polyphagia.
Polyphagia. The symptoms are polyphagia, polyuria, polyphagia. There are some others associated symptoms like unexplained weight loss, severe weakness. এই এগুলো টোটাল লেভেলে প্রাইসকে পাবে না, আর যখন পরবর্তী তাহলে ডিগ্রি কোর্স আমরা এগুলো জানতে হবে পলিউশন, পলিউশন, পলিউশন and unexplained weight loss and severe weakness is the symptoms of hyperglycemia. Okay, type 2 diabetes. Diagnosis criteria. The criteria of defined diabetes: fasting blood sugar more than equal to 126. HbA1c 6. HbA1c criteria of 6. The question is more than equal to 6.5. Second, third criteria which is random blood sugar more than 200 milligram per day with symptoms of hyperglycemia. That's like polyuria, polyphagia. Okay, that's a model question. Okay, next, how to diagnose diabetes mellitus? What is the tools you can use to diagnose type 2 diabetes? One, your blood, another is your urine. Blood and sperm. What is the mechanism with the urine? First, we have to check the blood glucose level. Next, the HbA1c test for HbA1c. Next, urinary test.
The liver function test.
It's a complication. The diabetes diagnosis is one of the they are not important for diagnosis of diabetes mellitus. Fasting and BP. That is related with the complication of type 2 diabetes. Next, I will come in. Immunology, what we should look for in urine? Glucose blood sugar very type 2 diabetes mellitus to immunity keep up. So the practically what sister? Glycosemia. What is renal glycosemia? And what is the value of renal threshold?
188.
What happens during this time? What is the now why comes
Glucose here also.
Actually সবকিছুতে একটা বাঙালি বলছি এভরিথিং ইজ এ থ্রেশহোল্ড মানে কি বলবো ওয়ান লোড নেওয়ার একটা ক্যাপাসিটি থাকে ঠিক আছে 180 is that level of kidney in which it can absorb all the excreted glucose through the kidney. After that when blood level goes beyond 180 complete glucose absorption from renal tube is not possible. That's why some portion of glucose is excreted through urine. Next topic. Complication. Complication. First one is cataract formation. Right? The question is why this cataract occurs? Olein pathway is activated, glucose is converted to cervical canal. Why is this cataract formed? Actually, cervical has hygroscopic action. What is the meaning of hygroscopic? Yeah, that's why water is accumulated in cells of eyes. Yes, that's why cataract is formed. Another one is necropathy. Okay. Necropathy, what is the meaning of necropathy? Necropathy, what is the meaning of necropathy? Necropathy is a rare function of kidneys. How can you diagnose necropathy? But blood tests show how kidney function is related. What is the main function of kidney? Mainly keep nutrition. That is the main answer. Urea and creatinine. You can measure the urea and creatinine. You can measure the urea and creatinine to know the function of kidney. At the body neuropathy. So, এখন এটা সম্বন্ধে পরামর্শ বোঝা মুশকিল অ্যাকচুয়ালি যখন হাইপারগ্লাইসেমিয়া হয় ব্লাড গ্লুকোজ লেভেল ইজ হাই neuropathy develops burning sensation of the peripheral nerve. Treatment को जाना पड़ता है. There is two types of treatment. Treatment is totally different in case of type 1 and type 2. What is the mechanism of type 1 diabetes? Complete or partial loss of insulin. So in case of type 1 diabetes, only treatment is insulin. There is no other option for treatment of type 1 diabetes. Only one insulin. Okay. In case of type 2 diabetes, there is several modes of treatment. One type is lifestyle modification, another is drugs. মানে যেগুলোকে আমরা বলি solid oral hypoglycemic drug. There are several drugs. Another is last stage is টাইপ 2 মানে ইনসুলিন, ঠিক আছে? টাইপ 1 এর ক্ষেত্রে only one and only insulin, আর তুই যেটা বলছিস immunology তে supplements not সেটা একটু জানা কথা না, আমরাও এখন জেনে পাই সব কিছু জানতে পারি, ঠিক আছে? এইবার বলে যে আচ্ছা আর একটা হচ্ছে যে পজিটিভ টেস্ট, পজিটিভ what is the full form of positive or how it is done?
Not so much severe.
I'm asking about for whom it is done. Now, actually, patent এর জন্য করা হয়। এখন নরমাল পেশেন্টের জন্য করা হয়। So what is the procedure? Can you tell me the procedure for positive test? How many glucose is taken? How many glucose is taken? And how to take? And what is the preparation? Psychology
Preparation হচ্ছে নরমাল ডায়েট, মানে যেদিন টেস্ট করা হবে তার আগে 3 দিন নরমাল ডায়েট খেতে হবে, আর 50 ক্যালোরি একদম নরমাল সেটিং করতে হবে। যেদিন টেস্ট করে তার আগে মানে ফাস্টিং করতে হবে।
What is the meaning of moderate fasting?
12 ঘন্টা
At least 8 hours of fasting. What is meaning of fasting? Fasting without any energy food intake. সে কিন্তু জল খেতে পারে না, আমরা যেটা ইঞ্জিনিয়ারে ভুল করি আমরা বলি যে না জল খাওয়া যাবে না। আচ্ছা
তারপর স্যার 75 গ্রাম সুগার, 300 ml ওয়াটার, so we put একবারে টেবিল পাস।
how many times? What the time?
What the time? Within 5 minutes in the
I don't get it.
5 minutes in the তারপর সবার ম্যাক্সিমাম লাস্ট ঘন্টা করব।
সবার সাথে করে সবার আছে সবার সাথে সিঙ্গেল মানে 0 1 2 স্যার এখন তো মেডিসিন গুলো আপনাদের মেথডে দিয়ে বেসিক্যালি বলা তারপরে ইফেক্ট আছে এটা কিন্তু সেটা ক্লিয়ার না প্রিপারেশন হ্যাঁ ডেইলি প্রিপারেশন এবার ক্রাইটেরিয়া যতগুলো পয়েন্ট লেখা আছে সেটা কি কি লেখা আছে gestational diabetes relations criteria. At times in fasting blood sugar less more than 95 mg per dl, first of 180 mg per dl, second of 155 mg per dl. Any two criteria, if you get any two criteria, we call it GDL. So তোমাদের কাছে কোশ্চেন আছে? Competition it is diabetic acidosis. Diabetic acidosis very type 1 and type 2 non-diabetic hyperosmotic coma. It is all about diabetes. Any question from your side? কোনো কোশ্চেন নেই তো? বুঝতে পারছিস তো? তাহলে বাড়িতে কি হ্যাঁ বুঝতে পারছি কোশ্চেন লাইকেট হিমোগ্লোবিন alpha and beta chain থাকে glycation of hemoglobin glycation of phosphate chain of hemoglobin alpha and beta amino acid to polychain একটা amino acid তার n-terminal থেকে close কোনো এনজাইম লাগে অটোমেটিক্যালি যখন আলফা-গ্লাইসিন থাকে গ্লুকোজটা গিয়ে পলিপেপটাইডস এ n-terminal এন্ডে গিয়ে লেগে যায় এটা হচ্ছে পরে কিন্তু সেপারেট হয় যত সুগার গ্লুকোজ বাড়তে থাকে তত ক্রমাগত গ্লাইকেশন করতে থাকে ঠিক আছে আর এটা হচ্ছে এভারেজ ডিউরেশন যেটা এক্সপেরিয়েন্স জানতে পারবে কতদিন ব্লাড প্রেশারটা মেজার 3 to 4 months এই জন্যই তো এখন চলে এসেছে অ্যাকচুয়ালি যেটা হয় যে ফাস্টিং আর পিপি ব্লাড সুগার মেজারমেন্ট এটা হচ্ছে অ্যাকসেপ্ট তুই খাওয়া দাওয়া চেঞ্জ করলি করলি তুই মিষ্টি খেলি ব্লাড সুগার লেগে যাবে তো এইচবিএনসি টা তো ভেরিয়েবল So over the 1 or 2 months or 3 months, it is stable condition. That's why it has come under the criteria. So that is type 2. So what is your opinion about genetic test? Genetic test? 5 ml agent. এর তো তোদের একটা কোশ্চেন না পরীক্ষায় অনেকটাই জিজ্ঞাসা করছি মানে বাংলাতে বলছি মানে বাংলা বুঝে না একদম কথা বলছি ইউ ডোন্ট নো বাংলা ঠিক আছে মানে আমি tell me some substance which can give rise to genetic test positive non-sugar substance non-carbohydrate substance name some non-sugar substance which can give rise genetic test positive. বুঝলি? এটা কিন্তু তোদের মারামারি কোশ্চেন ছিল এমসিকিউ ছিল আর আমি ইস এন্ড এভরি যারা আমার কাছে পড়েছে আমি তাদের কাছে জিজ্ঞাসা করেছি এই কোশ্চেনটা এবং এটা কিন্তু বেনেডিক্ট টেস্ট এর ধরবে মানে যারা বেশি নম্বর পেতে যাচ্ছে anyone at least one একটা চারটে রেসিপি আছে আর একটা হোমোজেনিক অ্যাসিড আছে না অ্যাসকর্বিক অ্যাসিড হোমোজেনিক অ্যাসিড আর গ্লুকোনিক অ্যাসিড গ্লুকোনিক অ্যাসিড ঠিক আছে এই অবস্থায় ছিল করতে হবে বাই নেক্সট টু ভোলাটাইল সাবস্টেন্স না বললে পড়ে যাবে বারবার লিখে না কিন্তু তোমাদের বেটার আমার বক্তব্য তোমাদের জন্য তিনটে কোশ্চেন আমি জিজ্ঞাসা করলাম ফ্রম ইউর এক্সাম তোমরা কিন্তু সেভাবে অ্যান্সার করতে পারো না ফার্স্ট হচ্ছে ক্যাটারাক্ট ফর্মেশন সেকেন্ড হচ্ছে ওজিটি থার্ড হচ্ছে অ্যাডমিশন criteria for diabetes mellitus both these phosphate সেটা তো মেটাবলিজম গ্লুকোজ মেটাবলিজম থেকে শর্ট নোট দিয়েছে
Today our topic is autonomic nervous system. autonomic nervous system. What is autonomic nervous system? Any idea? So autonomic comes from something automatically. That part of the nervous system which does not depend on the conscious brain for its action. So which part of the nervous system, which activities do not depend on the conscious brain? Our heart function. Throughout life, if you live 100 years, all the 100 years it's pumping about 70 beats per minute. Whether you are aware or not aware, whether you are awake or sleeping. Similarly, respiratory system. However, in respiratory system, many of the muscles are voluntary muscles, skeletal muscles, and respiration itself does not depend on consciousness, but respiration rate, respiration depth of respiration or rate of respiration, both you can voluntarily control. So to some extent, it is controllable, but you cannot stop respiration altogether. If you keep your respiration stopped, if you hold your breath for 1 minute or at the most 2 minutes, at one time you will have to succumb and your respiration will start. You cannot keep stopping it for minutes together. As I said, 1 minute is a standard, at the most 2 minutes you can keep your respiration stopped. But for heart, even that you cannot do. Even for a second, you cannot stop the heart. So autonomic nervous system is that part of the nervous system which works automatically and does not depend on consciousness. Without the aid of consciousness, it works. Similarly, all viscera, all smooth muscles of the body, as I said, heart, also the esophagus, the stomach, duodenum, whole of the small intestine, whole of the large intestine, everything is controlled automatically. So they are under control of the autonomic nervous system. Heart under control of the autonomic nervous system. All viscera, control of the autonomic nervous system. All blood vessels are under control of the autonomic nervous system. And to some extent, the endocrine glands also. Blood vessels, very important. Whether there will be vasoconstriction or vasodilatation, it depends on the autonomic nervous system. Even pupil, whether it will constrict or dilate, that will depend on the autonomic nervous system. Now, autonomic nervous system is divided into two parts: sympathetic nervous system and parasympathetic nervous system. Before we go into what is sympathetic and what is parasympathetic, a little more about autonomic nervous system. In autonomic nervous system, in all reflex activities, as you by now you have understood, autonomic nervous system, the activity does not start from the brain. It works automatically in a reflex, through reflex action. But this reflex action, there is no definitive afferent limb. You know all reflex actions, the parts of a reflex arc, you remember? A receptor, afferent limb, center, efferent limb, effector organ. Effector organ usually muscle. So receptor, afferent limb, the center, the efferent limb or motor limb, and the effector, usually a muscle. It may be a gland also. In case of autonomic nervous system, glands are as common as muscles. But in autonomic nervous system, the afferent limb is poorly developed. Very often, there is no afferent limb, autonomic afferent limb. There is the general afferent limb. For example, you touch something on your tongue and your mouth starts salivating. All the salivary glands start secreting saliva. But it does not depend on any autonomic stimulation. It is a simple somatic stimulation. Touch. Touch is a somatic stimulation on the tongue. The receptor is a somatic touch receptor. But the result, salivary secretion. The result is autonomic. So, this is why in modern terminology, autonomic nervous system is also called but still autonomic nervous system is very much in the vocabulary in the literature and in our syllabus prescribed by NMC, it is clearly written autonomic nervous system, which is one of my lectures. 10.5, they write PY 1.1, 1.2, like that. All nervous system lectures are under 10.1, 2, 3, 4, etc. And this is 10.5. There are two chapters under 10.5. One is, the previous day I already taught it, reticular formation and reticular activating system. And the second is autonomic nervous system. So there it is not written visceral motor system. But nowadays if you read the present day literatures, very often in various papers, research papers, they use the term visceral motor system because mostly they are related to viscera and some people call autonomic nervous system is the nervous system related to all visceral and vasomotor activities. Autonomic nervous system is that part of nervous system which is concerned with all visceral and vasomotor activities. Vasomotor means motor actions of the blood vessels. What are the motor actions? Vasoconstriction, vasodilatation. Bas, only these two. This definition I got from Gray's Anatomy. I did not read recently, but long back I got this definition that autonomic nervous system is that part of the nervous system which deals with all visceral and vasomotor activities of the body. So, visceral motor system, another name for, again come back to two parts, sympathetic and parasympathetic. Sympathetic comes from the origin, where these nerves are originating. Okay? From there we say whether it is sympathetic or parasympathetic. Very easy. If it is craniosacral, the nerve can originate either from the brain or from the spinal cord. There is no other source of origin of nerves, motor nerves. Motor nerves. See, if these motor nerves, which are part of the autonomic nervous system, if they origin either from the cranial or from the sacral segments of the spinal cord, either from the brain or sacral segments of the spinal cord, in short, craniosacral outflow, then it is parasympathetic. Rest assured, these autonomic nerves are parasympathetic. If it comes from thoracic, cervical is also included in the thoracic. So, you can say cervicothoracic or from the lumbar. So, in short, it is called thoracolumbar outflow. Better, you say cervicothoracolumbar outflow. Then rest assured, these nerves are sympathetic. They belong to the sympathetic nervous system. So, craniosacral, parasympathetic. Any autonomic nerve arising from either cranial or sacral, parasympathetic. Thoracolumbar, I said cervical included in the thoracic segments. Cervicothoracolumbar, sympathetic. Where do they originate? They originate from in the spinal cord, they originate from the lateral horns. You know anterior horn? Or all motor nerves, somatic motor nerves originate from the anterior horn. All sensory nerves come from outside, from the periphery, from any receptor. It may be a touch or pain or X or Y, Z, any receptor. These nerve, sensory nerves, they end in posterior horn. So anterior horn cells, originator of somatic motor nerves, posterior horn cells, somatic sensory nerve, and lateral horn, that is origin of autonomic nerves. If it is cervicothoracolumbar segment, then they are sympathetic. If it is sacral, they are parasympathetic. If it is cranial, what are the cranial nerves related to the autonomic nervous system? You know how many cranial nerves are there? All of you must know. How many? I am a little hard of hearing. You said, what number he said? Huh? Okay. How many cranial nerves are there? Huh? He said 7. Nudinal, wow, very fast acting. How many cranial nerves are there? Hmm? 8. 12. I thought I am hearing wrong. I am hard of hearing. Some say 7, some 8. You were still in class 7. Huh? ওগো 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 তামাক থেকে আনো, ভরে আনো জল, ফেরে আনো হুকো, করেছো তো? আমাদের আরেকজন স্যার বলতেন, ওরে ও ও তো টিনি, তুই এমন ফন্দি হেঁটে গরু ভেড়া আনলি হাটে। আমাদের আরেকজন বায়োলজি স্যার স্কুলে পড়াতেন, উট্টা ফেগওয়া, উ উ উ ও ও ও উ টি টি এ, উট্টা ফেগওয়া, এফ এ জি ভি এ এইচ, উট্টা ফেগওয়া। 12 cranial nerves, olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, auditory, glossopharyngeal, vagus, accessory, hypoglossal. Remember where I was appearing in the Viva in my pre-final ENT examination, one very famous person came as an examiner and he asked me some question I could not answer. You can't answer this, you bogus student, don't read anything. Tell me the name of 12 cranial nerves. I said olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, auditory, vagus, accessory, hypoglossal. Because I knew Utta Phagwa. You are a good student. How come you could not answer this question? Sit down. Bring tea. So he offered me tea. So even in your final year ENT exam, you may be asked this question. Don't think it is class 10 or class 11's question. You can forget now. Who knows, maybe you will be appearing in NEET exam this year again and get a position in medical college and go. So you will have to know all the 12 cranial nerves. By saying only 12 cranial nerves, I passed my ENT exam. এই রকম 10-12টা আছে। But I don't know anything in English except this Utta Phagwa. Out of these 12 cranial nerves, what is the third cranial nerve? You, good student, tell me. Okay, I will go to this way. What is the name of the third cranial nerve? Good, right, good. What is your name? Devanjan is good student. He said oculomotor is third. What is seventh cranial nerve? Ah, good. So these are, I think, good students are there, na? What is the ninth cranial nerve? Oh, fantastic. What is the 10th cranial nerve? Huh? Vega. This side of good students. So, remember these cranial nerves, 3rd, 7th, 9th and 10th. Oculomotor, facial, glossopharyngeal and vagus. Oculomotor, facial, glossopharyngeal and vagus. OFGV. So oculomotor is one cranial nerve which is related to cranial outflow. Then comes 7th or facial. So 3rd, 7th, 9th and 10th. Facial nerve. Then glossopharyngeal nerve. And last, vagus nerve. So how is oculomotor nerve related to autonomic nervous system? Oculomotor nerve, one part of the it is a motor nerve. All muscles of the eyeball are supplied by the oculomotor nerve, except remember all three SO4 LR6. You remember it? Your anatomy teachers, oh, they don't give you these mnemonics. They hate mnemonics. So I remember the mnemonics, and from that only I am telling all three SO4 LR6. If you remember all the muscles of the eyeball, superior rectus, inferior rectus, lateral rectus, medial rectus, superior oblique, inferior oblique. Superior rectus, inferior rectus. Rectus means straight muscle. Lateral rectus, medial rectus. Superior oblique, oblique muscle. Inferior oblique, oblique muscle. Only a day after, when you do the practical, you will learn how to test all these 6 muscles. And all these 6 muscles, except 2, are supplied by. So remember this chemical equation, all 3 SO4 LR6. All muscles of the eyeball are supplied by the 3rd cranial nerve or oculomotor nerve, except superior oblique by the trochlear and lateral rectus by the abducent. SO4 LR6. Please remember this equation. This is a mnemonic, not actually any chemical equation. So this mnemonic says rough supply of the muscles of the eyeball, all 3 SO4 LR6. SO means superior oblique, LR means lateral rectus. So if there is paralysis, lower motor neuron type of paralysis of the 6th cranial nerve, what will happen? Lateral rectus muscle will be paralyzed. So if the lateral rectus muscle will paralyze, the eyeball will deviate to the medial side. Medial side. If left lateral rectus is paralyzed, left eyeball will be deviated to the medial side. So this is called medial squint. Tera. In Bengali we call it Lokhi Tera. Medial squint. Did you follow what I mean? Or everything looks Greek? Anyway, it will come to that later on. Even before you come to the theory, you will learn in practical class. Maybe in a week or 2, you will learn this. So, but one part of the oculomotor nerve, it goes to one nucleus whose name is Edinger-Westphal nucleus. So, some part of the oculomotor nerve, some fragment of the oculomotor nerve, it enters a ganglion. Ganglion means collection of nerve cell bodies. It enters a ganglion known as Edinger-Westphal nucleus. Some from their fibers come out. That goes to another again called as postganglion, preganglion, postganglion. So this is called the ciliary ganglion. From their nerve fibers arise, which supply the ciliaris muscle, the sphincter pupillae. So when the sphincter pupillae muscle around the pupil, so when it contracts, it constricts the pupil. The pupil becomes smaller in diameter. So sphincter pupillae So from cranial nerve nucleus, it goes to the Edinger-Westphal nucleus, preganglion. From Edinger-Westphal nucleus to the ciliary ganglion. From there, postganglionic fibers will arise and supply the ciliaris muscle. Ciliaris muscle causes constriction of the pupil. It is around the pupil in a circular way. So when it constricts, the pupil will constrict. When it contracts, the pupil will constrict. So there it is a parasympathetic nerve. I said from origin and ultimately from action, you can differentiate parasympathetic or sympathetic. All sympathetic nerve fibers ultimately secrete acetyl, all parasympathetic nerve fibers ultimately secrete acetylcholine as a neurotransmitter, whereas all sympathetic nerve fibers at the nerve ending secrete one neurotransmitter known as, not adrenaline, but noradrenaline. So it is noradrenaline secreted by the postganglionic fibers. That means intermediate there is ganglion, and postganglionic fibers will end in the affected organ, either a gland or a muscle. Okay? So what is the difference between sympathetic and parasympathetic? Sympathetic fibers secrete noradrenaline, parasympathetic fibers secrete adrenaline. Then what about the seventh cranial nerve? It is a motor nerve, simple somatomotor nerve. It causes contraction of all facial muscles. So it is called the nerve of facial expression. How come it comes to be a part of the autonomic nervous system? Yes, there are fibers which first go to the superior salivary nucleus, then it goes to the lacrimal gland, submandibular gland, and sublingual gland, not parotid gland. So from seventh cranial nerve, which glands are supplied? Lacrimal gland in the eye, which secrete tears. Submandibular, submaxillary, and sublingual, they secrete saliva. They relay in the superior salivary nucleus. But ninth cranial nerve, the glossopharyngeal nerve, it goes to the inferior salivary nucleus, and from there it supplies the parotid gland. The one which was missing for seventh cranial nerve is now found out in the ninth cranial nerve. So parotid gland is supplied by the ninth cranial nerve. That is also a parasympathetic autonomic nerve. So when these nerves are stimulated, if the seventh nerve is stimulated, there will be salivation, though not from the parotid, but from the other salivary glands, and there will also be tears coming from the lacrimal gland. When the parotid gland is stimulated, when the glossopharyngeal nerve is stimulated, then the parotid gland will be stimulated, and again saliva will be produced, but not from submaxibular or sublingual or submaxillary, but from parotid gland. 10th cranial nerve, it takes the major share of parasympathetic activity from the cranial outflow. Major share means lungs, heart, esophagus, stomach, duodenum, jejunum, ileum, whatever you know, whatever I remember, I am telling you. Huh? Cecum, ascending colon, transverse colon. Now stop. Up to 2/3, 1/3 junction of the transverse colon, vagus action is over. And who takes over? Rest of the large intestine? I said cecum, under cover of vagus. Ascending colon, vagus. Even part of the transverse colon, 1/3 of the transverse colon, vagus. What about the 2/3 of the transverse colon? The descending colon, then the sigmoid colon, rectum, anal canal. These are also parts of viscera, abdominal viscera. They are supplied by the, what is left? Parasympathetic, sacral outflow. They are supplied by sacrum S1, 2, 3, 4, etc. S1, S2, S3, S4. They supply part of the transverse colon and whole of the colon after that. That means descending colon, sigmoid colon, rectum, anal canal. So that is the beginning of the parasympathetic, craniosacral. Now about sympathetic. The craniosacral, which organs? One I already said, part of the later part of the GI system, beginning from say half of the transverse colon to rest of the large intestine. But what about other organs? Do they supply any other viscera or organ? Yes. All parts of the female genitalia, all parts of the male genitalia. These fibers go to the pelvic plexus. In the pelvis there is a nerve network called pelvic plexus. There are nucleus, there are also neurons. And from those nuclei, fibers arise, postganglionic fibers arise, and they supply part of the large intestine and all of the female genitalia, whether it is uterus or it is fallopian tubes or urinary bladder, etc., etc. And this part also. That means in male prostate, again urinary bladder and ureter, urethra, etc., etc. Now, the junction where the postganglionic fibers enter the target organs. It may be urinary bladder, it may be lacrimal gland, it may be the heart or lungs. That is called nerves in passante, nerves, N-E-R-V-E-S, in passante, where the nerves meet with the effector organs. Now, what are the functions of the parasympathetic nervous system? They secrete acetylcholine. Can you tell me any substance which very, very strongly mimics the function of acetylcholine? I think all of you have seen it. Anything in almost everybody's house you will find it, but nowadays you may not find. Anybody? Have you heard the name Baygon spray? Anybody heard the name? Anybody who have not heard the name? Oh, I know. Baygon spray? Anyway, days are changing. Maybe you are using mosquito repellents and these. So these are called insecticides. Very extensively used by farmers. Very extensively used by farmers and also in household to kill mosquitoes, to kill cockroaches. Those insecticides we use. Now what that contain? That contains a chemical which is known as organophosphorus compounds. Organophosphorus compounds, strong insecticides. At one time, one organophosphorus compound was extensively used by agriculturists, farmers. Polydol was very famous. Have you heard the name? Polydol? Anybody? So in older days we used to get, I think in now modern days also, lots of organophosphorus poisoning. Taking polydol, taking TIC20, taking this, taking that. I remember I was that time working in a village hospital. So as I was working in the emergency, there was a big, huge uproar. Lot of people are shouting. They are using all sorts of slang words that can be applied to a person. So all those slang words were being applied by lots of drunk people, all are local mastans and their followers, and those slang words were addressed to the doctor. And the only doctor there was myself. Why? They are bringing a toxic 26-year-old young man who has taken lots of polydol because he wanted to marry a girl and the girl's father did not get her married with him, and that same evening that girl was married to another boy by the wish of the girl's parents. And this boy, thinking what to do, he took a bottle of polydol and drank it. And that time, what happened to him was an excellent example to what happens when you stimulate the parasympathetic system. Why? There is one enzyme known as acetylcholine esterase. Yes, acetylcholine is secreted by all parasympathetic nerve endings. Do you agree? So far as what we have heard, acetylcholine is secreted by all parasympathetic nerve endings. Do you agree or no? Huh? Nurin, tell me, you agree or no? Agreed. At least one person agreed after I asked. So, there is an enzyme which immediately breaks down this acetylcholine. This is called acetylcholine esterase. So, acetylcholine is secreted, it performs its function, and then its function is, after a few minutes, its function is over because it is now destroyed by the enzyme acetylcholine esterase. But this poison, it blocks the enzyme acetylcholine esterase. So because it blocks the enzyme acetylcholinesterase, acetylcholine is not destroyed at all. All the acetylcholine secreted by the parasympathetic system in the body is retained as such, as acetylcholine. And it keeps on performing its function. So its function is stimulating the whole of the GI system, starting from stomach, esophagus, to duodenum, small intestine, large intestine, all parts of the GI system start stimulating. Then, acetylcholine, what does it do? It is still there, like the ghost. One person said, asked a sannyasi, I want a ghost. Whatever I ask him to do, he will do. He said, okay, I will give you a ghost, but you have to keep him asking for something or something. The moment you stop asking anything, he will kill you. He will first start dancing, more work, more work. And if he does not get work, he will kill you. So this person now, what he did, this acetylcholine also asked acetylcholinesterase, you kill me or I will kill the body. The body is not secreting acetylcholine. Yes, the body is secreting acetylcholinesterase, but its function is blocked by organophosphorus compound, which is a very, very strong acetylcholinesterase blocker. And this action is not temporary, it is permanent. For several hours it is there. So, what do I find? When the patient comes, in that 26-year-old boy who tried to kill himself because he did not get his lover as his wife, he started vomiting and diarrhea, as if you opened the tap water and gone elsewhere. So water is coming down. So diarrhea is happening. Then parotid secretion. What happens? All the parotid glands, and they come as froth. Severe dehydration, severe sodium loss, severe potassium loss. Heart will be stimulated. If you look at the knee, if you look at the pupil, what you will find? Strongly dilated. No. It is strongly constricted. It stimulates the ciliaris muscle. And there is severe pupillary constriction. The pupil is constricted, diarrhea, vomiting, frothing. Then, what is the action of vagus on the heart? It stops heartbeat. So heartbeat has come to minimum, maybe 30 per minute, 40 per minute. Okay. So some people might at the beginning think that it is a case of cholera. Cholera also same, severe diarrhea, severe vomiting, not stopping. But some other things you will find, that is pupiloconstriction. So treatment, what you do, give first. Treatment is atropine, and atropine. Not 1 ampoule, 2 ampoule, 8 ampoule, 10 ampoules you have to give at the beginning, it's intravenous. So atropine, what it does, it blocks the action of acetylcholine. So acetylcholine now cannot work. So slowly you will get, the pupil is getting dilated. So you can understand the features of, so what are the functions of acetylcholine? Start from the beginning. Pupils will be constricted. Okay? Salivary glands will keep on secreting. Vomiting. The GI, whole of the GI tract will keep on dancing like the ghost. And there is severe vomiting, severe diarrhea. Then there is vasoconstriction or vasodilatation. So the pressure will go down. When the pressure will go down, the person will tend to go to the state of shock. Except that the pulse rate will not go much. If the pulse rate is raised, pupil is dilated, you think your treatment is working. Understand? Very dangerous state of affairs. And the first, most important thing is, it tries to block the heart, stop the heart. Vagus has if you stimulate the vagus nerve, the carotid artery, see the vagus nerve supplies the stomach. Stomach is a weak point. In any wrestler's body, this epigastric region, stomach, is a weak point. The rib cages are in this side. So this is a very weak point. We don't do much exercise of this muscle. We do exercise of biceps and triceps and quadriceps and popliteal, all this. But we don't do much exercise of these muscles. So, what will a Kung Fu man do? He will hit on your stomach, the belly. And the stomach is usually supplied by the vagus nerve. Strong stimulation of the vagus nerve. Sudden burst of acetylcholine to the heart also, along with the stomach, to the heart also. From the vagus, heart will stop. The person, even if he does not die, he will be unconscious. If the heart stops, no blood supply to the heart, and the person will become unconscious, faint, lose consciousness. So remember these practical points. They're all very, very practical points. Then it also stimulates the bladder. There will be acetylcholine from the sacral outflow, S1, S2, S3, S4. They will stimulate the bladder. So the person will urinate also. He will wet all the bedclothes, the pants or pajama, whatever there is. Before going to heaven or hell, I don't know, for the loss of his lover, he will defecate, profusely defecate like water, and profusely urinate also. So, these are the things. You can easily learn what are the functions of the parasympathetic system simply by observing one patient suffering from polydol poisoning. If poor people or the old people also may suffer from polydol poisoning, they will suffer if the children put in their food or drinks some polydol, so that he dies and his assets, huge assets collected by the children. That is different story. Now, what are enough time, no? Oh, already 54. Anyway, so sympathetic. Let's go to sympathetic now. Sympathetic nerve, it is called the nerve of now. This moment. And parasympathetic is the nerve of tomorrow. So sympathetic is the nerve of now. If somebody comes to beat you, if somebody attacks you, what will you do? You tell me what you will do. He is reading quite a bit. If somebody comes to attack you, what you will do? Defend. Defend means how to defend. What you will do? That is very difficult. It will be activated. It is autonomic. You don't have to do it. You will try to fight. If there are some bold people here. If they are not so bold, what you will do? Flight. Flight means run away. So whether you run away or you fight, both ways your sympathetic systems will be awakened. It is the nerve of now. So your sympathetic nervous system, what it does? It causes pupillary dilatation so that you can see well, who is coming to attack me. Then there will be less secretion of from the stomach, less movement, because you don't want to bother your GI system when you are fighting. You will not feel any hunger. Even if you were hungry a minute before, you will forget about that because there will be no salivation. Parotid gland will stop working. It is by the parasympathetic that it will start working. And bronchodilation. The bronchus will take more air, so body gets more energy. Heart rate will, what are the 4 kinds of action on the heart? Heart rate, first is force of contraction will increase. Systolic blood pressure will increase. The force of contraction increase. This is called the inotropic effect. INOTROPIC, inotropic effect. Then there is chronotropic effect. Heart rate will increase. Force of contraction will increase. That is inotropic effect. Heart rate will increase. That is called chronotropic effect. Then dromo means to run. Aerodrome, where the airplanes run. Isn't it? Syndrome, the symptoms which run together are called syndrome. So drome means to run. So the impulses in the heart will run much faster. From the SA node it will come very quickly to the ventricles. So dromotropic effect. Conductivity will increase. The velocity of contraction inside the heart will be enhanced. So inotropic, chronotropic, dromotropic and bathmotropic. A very little bit of stimulation will cause contraction. So the action potential will be generated very fast. So this is called the bathmotropic. So what are the 4 effects of sympathetic stimulation on the cardiovascular system? Inotropic, chronotropic, chrono means time, heart rate will increase. In a fixed time, 1 minute, heart will beat say 100 times, not 70 times. So inotropic, chronotropic, dromotropic and bathmotropic. All 4 effects you will see in the heart or the cardiovascular. Pulse rate will increase. If the heart rate increases, pulse rate will also increase. And blood pressure will increase. Particularly systolic blood pressure will be greatly increased. So these are the sympathetic effects. Now sympathetic effects, they are done by several routes, not in one route like the parasympathetic. So one is called alpha, another is called beta. There is alpha, where there are alpha receptors, the alpha effects will be found. Where there are beta receptors, beta effects will be found. Interestingly, in modern physiology, we have found there is alpha 1 and alpha 2. Again, there is beta 1 and beta 2. Understood? It is very difficult to which one is beta 1, which one is beta 2, which one is alpha 1, which one is alpha 2. All these very difficult to remember. So I tried to find out some shortcuts. So I found one shortcut. I read it from one book known as Gadam's book. Nowadays it is not available. It's not a physiology book, it is a pharmacology book. You want to go? Alright, I will finish the receptors. Because nobody has told, so I have to stop.